Hi everyone, thank you so much for being here and helping us start off this conference. So, let me begin with a quick introduction to Ontario. So the province covers over 1 million square kilometers and it has a population of about 14.5 million people. Now about 80% live in urban areas. Now it does have a rather bureaucratic health system. Health policy is set by the Provincial Ministry of Health and it's implemented by regional authorities called LHINs or Local Health Integration Networks. Then you would have CCACs or Community Care Access Centres, and they would be in charge of actually contracting with other home care organizations to actually deliver the care. Now, CCACs were recently restructured and they now are under the more direct umbrella of the LHIN. Now, the province uses a combination of sources to really fund healthcare. So you have HBAM, or the health-based allocation model, and this makes payments based on patient contexts as well as hospital costs. And then there are global budgets, which provides fixed payments for a specific time limit. And then there are volume-based payments for quality-based procedures or QBPs. And these are payments made on a price times volume basis for following standardized best practices. So the province is really trying to move towards linking payments to better quality and value. And the integrated funding model, or the IFM, is one attempt to really accomplish this. So the IFM really requires people across professions, across organizations, across the acute and post-acute sectors to come together to collaborate while working with a predetermined amount of money. And the objective is to provide care for patients, and in this case, for 60 days post-discharge. So partners are just expected to transfer funds to a commonly held bundle or to each other that correlate with the expected use of a specific service or group of services. And so partners would be responsible for extra costs, but they would also get to keep any savings that are accrued as a result of this process. So the hope really is that efficient care transitions, monitoring at home, and encouraging self-management will eventually reduce the length of hospital stays, provide better support for the patient at home, whilst also reducing readmissions, hopefully, and hopefully costs overall. So in 2015, the ministry invited expressions of interest from acute hospitals as well as home care organizations who were interested in coming together as a group to deliver these models. So they received 50 submissions and they ended up selecting 6 of them, and these became the original 6 pilot programs. Now 3 focused on chronic obstructive pulmonary disease and congestive heart failure, so COPD and CHF. So the map here shows you where they're located in the province. So I'm going to be focusing on these 3 programs specifically and how they reimagined integrated care, even as they, delivered it. So we conducted 36 interviews, so 12 with each program. I'm not quite sure how to go back. Okay. So the first 18 were done when programs were first implemented in 2016, and the next 18 as programs matured last year in 2018. So we included program leaders, managers, and clinicians, from physicians to integrated care coordinators. So this was across the hospital and community spectrum, and you see the numbers broken down here. So the transcripts were anonymized, they were coded, and they were analyzed using a cultural constructivist lens. So we were really interested in what mattered to programs and how programs were developed in response to unique conditions, as well as how they then went about tweaking these conditions and transforming things as they went along. So Program A. Program A involved 2 hospitals, a family health team, and a community care access center, so the CCAC. The program found it difficult, really, to agree on a price for the bundle in advance, and this was because the CCAC was unable to project a figure for the community care component of the bundle. And this was because they had really been providing care for a subset of patients all this time, whereas now they would be expected to provide care for everyone. And furthermore, even if two patients receive the same level of care in the hospital, of course, their needs in the community would vary depending on social complexity and that sort of thing. Now, the two main hospital and community partners had a pretty well-established relationship, and they had a mutual appreciation of quality improvement cycles. There was an understanding that this would take time. So they both agreed to wait and reconcile on a quarterly basis, based on actual data after maybe 20 or 30 patients had actually been through the program. Now, 2 years later, the partnership was thriving, and partners had really reconceptualized the funding component of the bundle. So partners had signed a gain and risk-sharing agreement, and basically partners agreed to put money into a shared pot that was proportionate to their savings. So the plan was that this would then be reinvested to forward other bundled conditions. So as a hospital leader explained here, it was really a gain-sharing and risk-sharing model that we wanted to do as opposed to a bundle. Now, what other hospitals did, and I personally thought that this was the wrong way because it creates an us versus them notion, other organizations were taking money away from the CCAC and pulling it into the hospital and then providing that service or vice versa. And I wanted a partnership model. So during its first year, the program generated a paper gain, and because despite a reduction in hospital length of stay, beds couldn't be closed because it would just be occupied by someone else. Now, for some in the LIN, this didn't really matter because patient outcomes were so phenomenal, but others disagreed. So a LIN employee, for instance, complained that there was far too much emphasis in her own organization on the transfer of money, and there was very little acknowledgement that they were now able to basically serve far more people for less money, or at least for the same amount of money. Hospital participants agreed with this sentiment, right? They basically said the LIN didn't get this model. So the LIN kept pushing us. What are your financial outcomes? When are you going to bundle? When are you going to do this? When are you going to do that? And the community partner and the hospitals at the time said, our model is different, like leave us alone and we'll get there. So she went on to say, this is really not a savings strategy. And I think if we think it is, we're fooling ourselves as a province. In the long run, however, it is going to save us oodles of money because it's cost avoidance. Now, the IFM was also funded through the transfer of quality-based payments, or QBP funds, into the bundle. So in order to qualify, IFM patients had to meet stringent QBP eligibility criteria for COPD. But of course, other comorbidities might come into play. So by the end of their care journey, patients might not be COPD qualifying QBP patients. So this meant that hospitals had to scramble to figure out where to transfer funds from. So as one participant suggested, a more global funding approach that did not pigeonhole patients into specific funding pots would probably better address clinical complexity. And someone else suggested perhaps instead of having a COPD navigator, they could have a general navigator that followed them for all their needs. So moving on to Program B, this was the most ambitious in scale. It reached LIN-wide and it included 15 partners. Now, its bundle holder that managed the funds was also the hospital that had pioneered this approach at its own site, and then it was spread across the province. Now, this program had very strong leadership. It had a pricing model that accounted for different risk scenarios, but unlike other programs, the coordinators at this one had to really figure out, often on the go, how to put in processes that accounted for this large scale. So in the words of this coordinator, every hospital has a different set of rules, a different set of union rules, a different set of ideas about how they could function. There's a lot of opinion in everything you do, and every decision you make now needs to go through 9 hospitals. If you want to change a weekend rotation for the coordinators, you have to have 9 hospitals agree, and guess what? They don't. So participants found early on that one of the main challenges of implementing such a large-scale program was really negotiating differences in practice, size, location, experience, resources, you name it. So some had more stringent privacy cultures than others, right? Some were teaching hospitals, others served much more rural patient populations, and this would then require coordinators to traverse large geographical distances to provide care. So now 2 years later, there was an even greater appreciation for the differences across hospitals, as well as the additional complexities of scale. Now, the lead hospital had gone from an organization of 12 co-staff where everyone knew everyone else pretty well to about 70 or 80 providers who were struggling to identify who was the appropriate person to talk to during virtual rounds, for instance. And there was a new realization that there were components of the model that really could not be standardized because of these significant differences across organizations. And there were a couple of smaller hospitals that really they were forced to stop running the program just because of smaller volumes. And there were also complaints about uneven buy-in at this point. So participants were now in the process of discussing how the model could be extended from 60 days to 1 year, or perhaps even beyond. Now, this was partly in response to low enrollment rates because some patients had been reluctant to participate in the program because it would have meant giving up their existing PSWs, their personal support worker, that had been provided to them by the CCAC for the length of the program, and then perhaps have to deal with wait lists to get another one, and there was no guarantee that they would be given the same person. So they were refusing the program as a result. There was also a renewed awareness that people with chronic disease really needed ongoing monitoring. So the lead hospital was now considering a restructuring of the bundle so that each hospital would have greater autonomy and some sort of fiscal responsibility for the care they provided. So as you see this participant saying, I think how we structure the bundle going forward will be very important. We're big. We have 9 hospitals who are part of this. I think in the long run, we need to ensure that each hospital keep those bundles within the influence of the organization. Because if our cost per patient was much higher and we weren't performing as well as another hospital, the challenge with the way the bundle is structured now is that it averages out across everyone. So there's, in theory, a little less incentive for hospitals to be really pushing the envelope and to be innovating because they just don't get as direct an impact from that, right? So it was really just this move for more local autonomy and control over this bundle. So moving on to Program C. So Program C included an acute care hospital that acted as bundle holder, a chronic care and a rehab center, as well as 5 community partners. Now, during the early stages of program design, the hospital had been rather surprised to discover that only a small percentage of patients in the community were getting care from the CCAC. And this was partly because of the many layers involved and partly because of the lack of a feedback loop back to the hospital. So the hospital was very concerned that patients were getting lost in the community once they were discharged. So it decided to deal with this by applying for community service status, and this would then allow them to basically contract directly with these service providers and pretty much bypassing the CCAC. So this was, this made hospital participants rather happy because they had a new sense of control and autonomy now. They quite liked having a feedback loop to the community that let them know exactly what extra services were being delivered, whether specific patients perhaps needed different sorts of services, where extra costs were coming from. When the patient returned to the emergency department, the hospital had a very good sense of what care had already been provided, and they had a good sense of the history of these patients. And both partners, the hospital and the community partner, developed a trusting relationship over time. So the hospital was able to also have a respiratory therapist who acted as a coordinator, and they were able to build a better relationship with the respirologist. And this was something that the CCAC simply had not been able to do. But now, 2 years later, the hospital's community service status expired. So now it was unable to financially sustain the coordinator role as well. So this meant that the program had to revert back to a CCAC-dependent model of delivering care. Now, by this time, the CCACs had been rebranded home and community care. So one participant spoke about the move back to working with home and community care is both a blessing and a curse. It was a blessing because programs had been facing low enrollment rates here too, right? Because patients were reluctant to give up their existing PSWs, and this would no longer be a problem. But it was a curse because the quality of patient care that was being received in the community was once again suspect, at least in the hospital's eyes. So as this participant says, What we realized is that if I'm Mrs. Jones and I've had Susie Q as my PSW for 6 months and I like her and I'm comfortable now that she sees me naked in the bathroom, I do not want to switch and I say no thank you. And therefore we can't take on anybody. But with home and community care, you're not going to get an educated, trained pool of people because our project is all about education. You can't ask, what module are you teaching? Oh, you're teaching module 4 this week. So you wouldn't have that kind of control. So hospital patients were worried that the acute and post-acute care sectors would be behaving like separate entities once again. They found it very challenging to discharge patients without knowing what would happen to them, without being in control of their care post-discharge. They really wished that integrated care had been sustainable for them, and they wondered if perhaps a different structured way of doing things in the community sector could have helped. And you see the sentiment here. So just like the QBP standardized pathways ensure best practices in hospitals, I think the community also needs to have some standardized pathways, especially for these elderly chronic disease management folks. So from dietary to pharmacy to transportation to social issues and all those things. So this widening of the care network would ideally be accompanied by a lengthening of the bundle, perhaps starting at in doctors' offices in the community, for instance, and certainly expanding it beyond its current 60 days to, probably ongoing standardized monitoring of these patients to ensure that their medication, their diet, their pharmacy needs, their appointments are all in order. So as one participant said, we really need to start thinking about our patients as patients and not as diseases. So regardless of the unique challenges faced by individual programs, participants across these programs were suggesting that to be truly sustainable, programs had to be reimagined. And this theme was articulated in a number of different ways. You see this in these quotes. So this is someone from Program B. We see so many times different providers going into the homes of people who are living in poverty with nobody and terrible conditions, but they're there to provide wound care or to teach about heart failure and those things. But they're not looking at what they're living in, and they don't have heat or food. It's not that person's job, and that this isn't just about the IFM. It's like the whole concept needs to be different. Someone from Program C. There's different ways of doing it than we're doing it now. I think by using existing community services like the YMCA as an example would be important to do. If we look not just through the lens of the Ministry of Health, but the Ministry of Recreation, the Ministry of Housing, you know what I mean? Like breaking down all the silos across the system. And someone from Program A, I'd give their acute portion up to 60 days, but I would keep them with a navigator forever. It's the right thing to do. What if we did a navigator and a nurse and a team on all COPD patients that walked into this hospital and they were followed? Think of the difference that's going to make in the long term for the healthcare system. So, to summarize, program participants made a number of recommendations. So instead of linking funding to single conditions, consider a more global approach, and this would hopefully better address clinical complexity. Adopt a long-term view of financial benefits. As one participant said, this will definitely save us oodles of money in the long term. Then connect patients to other programs and community spaces. Then extend the tenure of the bundle well beyond post-discharge. And finally, promote accountability by encouraging local level ownership of the bundle, as well as somehow standardizing pathways in the community. So now these are all ideas that call for a complete re-envisioning of integrated care in a way that's holistically, spatially, and temporally more expansive for the patient, but at the same time, more accountable and predictable for those delivering this care. So on the one hand, sustainability was contingent on having control, having autonomy, having predictability and accountability. And you see this with Program A, right, who opted for a retrospective gains and loss sharing agreement as a way of really exerting control over financial uncertainty. And then you have Program B, that wanted each hospital to have greater autonomy and fiscal responsibility across a shared bundle. And then you have Program C, who wanted to work directly with a new community partner, again, as a way of exerting some form of control over what was happening in the community. And on the other hand, sustainability was also contingent on a re-envisioning of patient care that went well beyond the scope of the IFM as it was originally defined. And imagined, really. So participants wanted patients to be approached holistically as patients with multi-morbidities, with both medical and social needs. They wanted them to be linked to other resources and other programs as needed. So this would really mean extending the spaces of care beyond the hospital to envelop spaces that have not traditionally been seen as within the purview of healthcare, right? So spaces of residence and leisure, for instance. And finally, it would mean an extension of the tenure of care well beyond the 60 days to ongoing monitoring that, kept on going with the patient potentially. Okay, thank you.